Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on mentors and motivators who are consistently reshaping, redefining, and rediscovering the field of medical health care. I am excited to welcome Dr. Angela DeRosa, otherwise known as Dr. Hot Flash, an expert in the field of anti-aging and preventative health with a special focus on women's wellness and female health care. Welcome to Redefining Medicine. I am so excited to have Dr. Angela DeRosa joining us today, otherwise known as Dr. Hot Flash. We'll get to that a little later. Well, thank you for being with us. So why don't you share your personal story a little bit and a little bit about your education and what brought you here today.
Well, thank you so much for having me. It's always wonderful to have the opportunity to spread the word about what we're doing in hormonal space in particular. I always knew I wanted to be a physician since I was 8 years old, so that path was always clearly delineated for me. What became a little bit of an interesting part of that journey was when I started experiencing perimenopausal symptoms in my 20s and 30s and trying to understand what was happening with me. And unfortunately, even though I was in the field of medicine and becoming an internist and really wanting to focus in the area of women's health, it was kind of ironic that I was also being horribly treated by the profession, having seen cardiologists for heart palpitations and runs of VTAC, having fatigue, depression, anxiety, hot flashes and night sweats. I saw a slew of physicians, and they all patted me on the head and basically said, there, sweetheart, go on a date night, eat better, and exercise more, essentially. So I realized that I was being poorly treated by my own professional colleagues while I was going through this journey. And in hindsight, I was going through menopause prematurely, which was quite traumatic in a young person, especially in the medical profession. So I really have made it my mission to understand hormones and to really not only take my knowledge as a clinician, but to also help change that paradigm of women's health through many parts of my career since that time. So although I knew I wanted to be a doctor since I was 8, I went along that professional, journey very, very easily in a lot of ways because I knew what I wanted to do. I didn't have a lot of deviation from that course. But personally, when I started having the symptoms of menopause in my 20s, it really derailed me quite a bit. So.
Did you at the time think that you were going through menopause?
No, I didn't. That's what was really difficult at the time because I was seeing cardiologists, endocrinologists, psychologists. Everybody wanted to give me medications from antidepressants to sleep pills to heart medications.
Thinking it was? What were they trying to diagnose you
Honestly,
with?
I think they thought I was crazy, which I know I'm a little bit, but not
I think we all are.
Not that much. But it was really kind of fascinating that my professional colleagues, even though I was in medical school and residency, were failing me, and they kept giving me these drugs which were really band-aids of symptoms of perimenopause and menopause at the time. So when I was going through that, I was not only very frustrating, but I actually got really pretty angry once I figured out what was happening to me, and that really spun my whole career in understanding women's health and hormonal health in particular and how it can help other patients, because I had to live that myself and how poorly and defiantly I was treated by my profession.
How were you able to embrace what you were being taught by these practitioners and your professors in medical school if you were struggling with with what your own physicians were trying to diagnose you with?
Well, at the time, it was really conventional medicine and thinking, and frankly, unfortunately, it's still very much conventional thinking in medicine, and you're trying to take in everything you can and just pass medical school and get through the long hours and shifts. So you really believe that what they're telling you is truthful and correct. I had no reason to believe otherwise, and it wasn't until much later that I realized that I was being really treated badly. I knew at the time I was personally being treated badly and how I felt about it, but medically I didn't understand it till much, much later as I expanded my horizons and understood hormonal medicine. So I took it at face value. What they were telling me was correct, which was really quite devastating.
So when you began to do your own research, what was the epiphany that you had that you realized?
Well, I realized as an internist, and as a female internist, a lot of women were drawn to me personally because I was a female and they wanted to be treated by another female physician. But I also started realizing that much of what I was doing in medicine was really slapping a Band-Aid on symptoms, and nobody was getting better, and everyone was doing this slow march to death, and all I was doing was really helping push them there with the hoping that maybe they're compliant with their medication. And it really became that aha moment when I figured out what had happened to me, that I go, okay, I know what my mission is. I am supposed to take this journey, and I am supposed to be the voice for all the patients who are treated like I am. And it's really amazing when I get people come see me in their office, they always start crying. But when I hear my story, they also know that I get where they've been. So I'm really kind of their little ambassador to really try to change the paradigm of how we think about women's healthcare in this country.
Now, how were you able to identify what was actually wrong with you?
It was actually through multiple mentors and different learnings. When I graduated my residency, I actually had the foresight of actually developing a women's health program in my internal medicine residency program, because I had a program director who was so evolutionary at that point. And when I created this little department, I was really a peon attending coming right out of residency, but it was at a 700-bed, very reputable hospital in Chicago. And all these pharmaceutical companies started courting me, in particular in the women's health arenas. And then from that point, I met all these international experts in women's health, and they hired me to be their senior medical director for the West Coast. So moving at that point from clinical into the dark side of pharmaceuticals early in my career, I had the opportunity not only to expand my clinical horizons, but also meet people that I would have never otherwise had an opportunity from all over the world. And as most people know from A4M, that most of the most progressive data and research is coming from outside of the US in relation to anti-aging. So it was really a gift early in my career, and through that clinical learning, I also figured out what was happening to me and what had happened to me.
So upon making the discovery of the benefits of bioidentical hormones and utilizing them yourself, how were you able to share that wisdom and implement that into either clinical practice or sharing that with patients or colleagues or what have you?
I always said that I probably became my own worst guinea pig nightmare, because I was trying every single hormonal therapy that I possibly could known to mankind on myself in my learning.
Well, you look phenomenal for 95. So.
Thank you. I don't know why we always say that we look so much, or our age is younger. We should say we're stated age is much older. But certainly I've done more damage in my pursuit of the truth and understanding hormones. But when I finally got it right, and it was really through discovering hormone pellets. I've been on creams, troches, gels, and most of those work okay, but it was really discovering pellets later in my career that I realized that I could get my life back. And what was also exciting about that is I was realizing through that avenue I could also give my patients their life back and get them better. And as I started taking that learning, I wanted to open a medical practice called DeRosa Medical, which then I ended up hiring multiple clinicians to come work for me, and then teaching them all about hormone therapy. So it's really about building this army of ambassadors of hormones at this point in my career, because it's really exciting as an internist when people just get worse and worse and more medications. We actually get them off medications. We get them feeling better. We give them their lives back. So it's really now that next step to take my personal and professional growth and journey to opening my practice, and now I want to expand that into training and teaching other clinicians so that it just keeps growing. So
let's go back and talk about your clinical practice and your preferred method of utilizing pellets as your ultimate delivery system for the bioidentical hormones. What is it about the pellets that you find most efficacious?
Well, I really like the sustained release and really the ability to have normal physiologic levels that are in a steady state. So unfortunately in some of the other deliveries, although they may be bioidentical and safe, you tend to get some of the ups and downs of the therapeutic levels throughout the day. So you may be too low half the day, too high. I really like that even steady state that you can obtain, and you're also more likely to get less side effects when you have a steady state. So, and another thing too, it's kind of like Ronco chicken, set it and forget it. So you can put those puppies in and you just don't have to think about it, because compliance, as you know, can be an issue as you have to remember to do things. So
right. Right, and they just dissolve on their own.
They just dissolve right on their own, so the
Right.
body takes them in and utilizes it as it needs it, and then it slowly dissolves, and the goal is to figure out the timing of when to put them back in. But given the fact that I went through menopause so early, I have a very high requirement, so I'm doing them almost every 2 months, but most patients that are doing them are 3 to 4 months, so for women. Men, it's a little bit longer.
So for yourself, did you ever determine what was the cause or the catalyst to make your body go through menopause so early?
A lot of times they think it could be genetically related. If your mother or your grandmother, you can typically track when you're going to likely go through menopause. Unfortunately, my mother had a hysterectomy. My grandmother never talked about it, so I don't know what ages they went through it. But given the exposure zone or environment, you think about the radiation, what's in the water, antibiotics in our food. There's all kinds of things these days. And these organs, the thyroid, your ovary, they're so tiny and they're so sensitive to environmental exposure. So who knows if I was exposed to something or it was just sheer dumb luck. You just don't know. But I think it was a divine intervention, because sometimes when things like that happen, it sets you on a trajectory to help other people. And I think that was my mission. I'm supposed to do this, and I think that was the catalyst to make this happen.
So getting back to your patients and the utilization of the pellets, so what kind of protocols do you use to monitor the benefits or risks thereof of pellets?
Well, whenever we see patients in the practice, we certainly want to make sure that we don't always make the assumption that everything's hormonally related, because there could be other medical issues from anemias. Could there be some underlying psychological disorders? Absolutely. But again, I don't want to ever say that it's all in our head, because it's certainly not most of the time. So we want to make sure that we do a good foundation of blood work, a full symptom assessment, a good physical exam, because we don't want to miss something else that it could be mimicking. So assuming that all of their baseline blood work and systems are a go and everything's good, we listen to their symptoms, and then we also check blood work. So one of the things that I find that clinicians miss the boat often is they only check an estrogen level. Well, that's really just a serum level of what's going on, but it doesn't really tell you how good it's working for that patient. So FSH, follicle stimulating hormone, is really the brain response to what's going on in that body, and that's the more important hormone to follow, and testosterone levels as well. So we want to make sure we're following blood work, and then once we put the pellets in, reassessing their symptoms very quickly. So we usually see people back in a month and do blood work again, assess their symptoms, and look at how good of a change or benefit we've had. And then the goal is to then see them back 2 to 3 months and ongoing over time to make sure that we get good effect. You shouldn't just put them in and leave them alone. We want to monitor it to make sure that they're getting the best effect that they possibly can with the least amount of side effects or no side effects, and that their blood levels are showing normal, optimized physiologic levels.
Does a woman have to be showing signs of menopause or in menopause to be a candidate for utilizing bioidentical hormones?
Well, it's interesting when the way you asked a great question to kind of hopefully get rid of a paradigm that most people think of. So when you think of hormones, we often think of hot flashes, night sweats, and the symptoms that women are having. And it's great to alleviate the symptoms because we want to obviously feel better. But silently, the body on the inside is changing. So when we lose our estrogen, the inside of our arteries are getting harder, so that may lead to blood pressure issues. Or when we lose our testosterone, we may not process and burn sugars effectively, so we may become pre-diabetic, which can then lead to all the other cardiovascular risks. So not only do we want to alleviate the symptoms, but we also want to heal the body from the inside out so that it's functioning at its optimal health and normal physiology. So it's really about preventing that chronic illness from developing, but also obviously feeling better too.
Now, there's been a lot of discrepancy, and especially if you go to a conventional practitioner, they will, err on the side of caution and say, no, you shouldn't be using bioidenticals, and it could increase your risk of breast cancer. Can you please try to dispel some of the myths out there?
It never ceases to amaze me how one article came out almost more than 10 years ago that has irreparably harmed women's health, I think, for decades to come. And that the fact is that there's been good research that has actually basically said that that study was bogus, the way they managed and reported it. But yet clinicians still dig their heels in their trenches, and they say, no, absolutely not. They can't seem to get beyond that one article when there's been article after article after article saying what was reported was false and data to support the complete opposite. honestly, I think it's just physicians don't want to take the time to understand hormones. They see it as this big mystery, kind of like women in general, and that they don't want to delve in and figure out how to really properly manage it. So if they don't understand it, it's easier for them to poo-poo it than to actually take the time to really get in and understand it, which is really a disservice to the patients.
Right.
But when you look at the data itself, even the everyone focuses on the breast cancer issue, but in that study, in the worst case, it was neutral for women in breast cancer. In the best case, it actually showed a benefit, even with these horrible products we never use anymore, Premrin and Prempro. And what we also don't talk about is testosterone for women, which wasn't in that study, actually decreases breast cancer risk and actually can decrease recurrence rates of women in breast cancer. So hormones aren't bad for the breast. And when you actually look at what's causing breast cancers, typically is being overweight, sedentary lifestyle, drinking too much. I mean, there are a million other things that have more risk than
Again,
hormones.
the environment.
The environment than any
Right.
hormones would ever have. But yet we focus there because it's easy to do so.
And oftentimes they're saying there isn't enough scientific data, but yet
No.
they haven't gone and searched for
Yeah,
it.
it just means they haven't looked at it.
Right. So I read some fascinating and disconcerting facts on your website
Okay.
that talked about oftentimes hormonal imbalances are not correctly identified and diagnosed within a conventional practitioner's
Yes.
office. So can you discuss the importance of a physician being properly trained and understanding really what they should be testing for, what they should be looking for, and so to eliminate the many poorly misdiagnosed hormonal imbalances and whatnot that are out there, so that way
I really see two different schools in there. So first off, we have the physician who just won't step outside of the box and even look at other things that may not be necessarily quote unquote conventional. And then there's also the other group of physicians who take a weekend course and then they jump in and they've just dabbled in it and they have honestly no idea what they're doing and they're causing harm as well. So it's really, really important to understand what to test and really educate yourself and get the education like A4M provides over and over again. It's not, don't just read one article, don't just attend one course. You need to really become expert in this subject matter before you really should be treating women or men and hormonal imbalances. But when you look at the conventional physician, they have been taught to only look at certain things, and if it doesn't fall in the strict, let's say, endocrine guidelines, that it must not be true. So it's really about understanding what other things you can be testing and how to properly interpret them, because if they fall outside of the normal reference range that everyone gets all excited about, they may say, well, you're normal, when in fact they may be highly abnormal, and they may not just be interpreting or looking at it properly. And then those who are jumping into this field, they need to make sure that they have the proper education to not harm women either, because they can be equally as problematic.
So let's move on to men.
Men.
I know one of your favorite topics.
Well, are they all?
So what are some of the symptoms associated with andropause, and what do you see in your practice?
Well, it's fascinating to me. I always use this joke. There's only two ways to get a man to a doctor, and one is with in an ambulance, and the other is with erectile dysfunction. So either dragging it's usually the wife dragging him in, and sometimes it is in an ambulance, but certainly it's usually erectile dysfunction that brings men to our practice. Although it's changing a bit because men are starting to identify that with this term andropause or male menopause. And frankly, it's really that they lose that killer instinct. They don't have the energy anymore like they once had. They may be putting on the midsection weight gain. They just don't have the libido or the drive for sex anymore. But by the time they usually get to our office, a large majority of them are already having erectile dysfunction and problems in the bedroom. But it's nice to see with this younger generation, because I think what they're being inundated on the news and on the commercials, that there are other things other than erectile dysfunction. And frankly, they'll deny it anyways. But it's usually the fatigue, the weight gain, the lack of muscle energy and endurance. They can't work out like they used to, so that's usually what brings them in.
So when you're testing for them for a low testosterone level, what would be a normal testosterone level?
So normal is somewhat of an arbitrary term, because what's normal for, say, one person may not necessarily be normal for another. So we have to be careful not to...
And age comes into play.
And age.
Okay.
So you need to look at, so we look at a range. So typically most reference ranges for testosterone in men are going to be somewhere between 250 to 1100, depending on the lab that you're seeing. But again, we're not waiting till the whole idea is you don't want to wait till they're extremely deficient. You want to optimize their level so that they're in that upper quartile. So on average, men are going to start to have symptoms usually when it drops below 500, and we want to replace up to that upper quartile of 8 to 1200 typically. But again, you have to customize it for each patient, because you may have one man who feels great at 700 who would feel horrible there, and another one who needs 1200 to really feel much better. So we have to tailor it to each individual patient.
So when a man goes to their conventional practitioner, and typically their practitioner will write them a prescription for that other pill.
Yeah.
So can you discuss the risks of doing that in lieu of doing hormonal therapy? Or should I say, can you discuss the benefits of doing testosterone therapy and negating the Viagra?
Well, the way I look at it is testosterone really is the foundation of the house. So if a man is struggling with erectile dysfunction, really that's a blood flow issue that those drugs are really managing. So for instance, the Viagras and Cialis, they're increasing the blood flow that's running through the penis to allow for the erection. But if you don't have a good foundation of testosterone, you may improve that blood flow, but it's testosterone that's really driving the underlying libido, the whole physiologic process for setting up for that erection. So if you replace the testosterone and they still have erection difficulties, then the foundation's replete, but then you can then fix the problem, which is usually due to high blood pressure, cholesterol issues, smoking that have caused plumbing damage to the house,
right. so to speak.
So we want to make sure the foundation, and that's the testosterone, and then fix the plumbing if you need to.
So can you discuss some of the risks of men having low testosterone and converting to estrogen and other hormones?
Both men and women struggle from testosterone deficiency, and so it really applies in that case for both. So typically when you look at men, and I kind of overgeneralize this, but on average, men make about 95% testosterone in ratio to 5% estrogen. Men are supposed to have a little bit of estrogen, even though when I tell them that, it really certainly bothers them. But women, on the other hand, are a 60-40 blend, where 40% testosterone and 60% estrogen. So we're actually more well balanced on those two hormones. But when we both lose our testosterone, we're both going to be set up for a lot of different dysfunctions. So first and foremost, testosterone is insulin sensitizes our muscles. So when we lose our testosterone, both men and women, we don't burn glucose effectively. So the very first thing that's going to happen is we're going to gain weight, and we're going to throw it right in the midsection, which is what drives cardiovascular risk. So really making sure that that testosterone is replaced is going to help us burn sugar, keep the weight off, but also prevent the cardiovascular risk. The other thing that testosterone, in what both men and women do, is it primes serotonin in the brain. So we start to have panic, mood disorders, most commonly apathy, which can be really dangerous in a relationship or in just how we feel about life. So both men and women start to struggle with that as well. Memory starts to go. So there's a lot of consequences with that. Interestingly, with men, as you alluded to, they can also convert too much of their testosterone to estrogen. So if that ratio becomes higher than the 3 to 5%, they kind of get the man boobs or the gynecomastia. They're kind of roly-poly in demeanor, like they just kind of look like a Pillsbury Doughboy. I know we all seen those kind of guys, but certainly they're more emotional. They get the gynecomastia. They just struggle with weight a lot of their lives, and oftentimes they also, I've seen over the years, they also struggle with male pattern baldness in addition to it, which is kind of fascinating, even though you would think that's more due to testosterone.
Right.
So the goal is to, and then they can also get hot flashes in the middle of the night, which then they can relate to us a little bit better.
So speaking of the hot flashes, so let's go to your friend nicknaming you Dr. Hot Flash,
yes.
and how that began, and then I'd like to move on to your book and how that all came about.
Well, my friend was, she came to see me actually, she was one of my dearest friends as a patient early on, and I had to fire her as my patient so I could see her friend, because it's not wise to treat your friends. At least you can give them advice, but I don't like to treat them. But she was the one, I just remember walking in and she goes, "Hey, Dr. Hot Flash," and it just stuck. Everyone started calling me that, and so now whenever I go out or I'm on my website, it's Dr. Hot Flash. It's just something that's easy to remember, and for me, it's personally relatable because not only am I a doctor that specializes in treating hot flashes, but I've also had a whole bunch of them.
Story.
A bunch of them myself.
So you penned a book a few years back and recently updated it called "How Your Doctor is Slowly Killing You: A Women's Health Survival Guide," and I know you recently updated it as well.
Yes.
So first of all, that title.
It is a bit igniting and compelling, I would say. Let's just say some of my colleagues didn't think it was a nice topic to hear about, but it was meant to be insightful in many, many ways. We have toned it down and changed the title to A Women's Hormonal Health Survival Guide, How to Prevent Your Doctor from Slowly Killing You. But it wasn't written for doctors, honestly. It was written for patients, and the topic was compelling, but the way I kind of looked at it is we're in the fight of our lives at times, and unfortunately the way medicine and its conventional wisdom is often working against that, and we continue to give patients more and more medications which aren't without side effects. They're very costly and they tend to make us sicker or sicker over time.
Right.
And if we're not careful as clinicians, I mean, women, I myself, when I was going through the perimenopause, I started getting up to 5-6 medications, and I was in my 20s and 30s. So we have to start thinking about things in a new way. So this book is really designed to train and teach women and men that there are hormones in our body that play a very instrumental part in how we feel and how our health goes over time, that we need to replace and we need to understand. And we need to not assume that our clinician understands hormones and that they have the best information in regards to this, and not accept status quo. We need to advocate for ourselves. So I really want to, and we need to give them the information to then take back to their physicians and nurse practitioners and clinicians to say, you know what, you may want to think about this in a different way. So it was meant to be compelling and get a little bit of attention. Unfortunately, some of my colleagues didn't really appreciate it, but it's not meant to be a dig at them. It really isn't. And most of us are out there doing the best that we can to help care for our patients. I'm just putting it out there to start the conversation that we may want to think about things a little bit differently when it comes to women's health.
I know you faced some criticism from your colleagues, but did you have any accolades from them as well, those that are not in this space?
Yes, I think the people who don't feel threatened by it, and women physicians in particular, seem to be more open to it. I found it interesting that it was usually endocrinologists and OB-GYNs who had the most issue with it, which is ironically, OB-GYNs are the ones that are caring for women. You would think they would want more of that information. And again, I'm overgeneralizing, but again, it wasn't meant to be a slight, and I never meant to criticize them. I just wanted to criticize the way of thinking that we're being given in the United States in particular about hormone health. But unfortunately, I've had to take some arrows on that one. But I'll do it. I'll do it over and over again.
I'm sure you will.
The fight is worth it.
So, as you know, Pamela Wibble, Dr. Wibble, will be speaking here. She is speaking on physician burnout. I know you had your own experience with that. Would you mind sharing it with us?
Well, certainly. When I was building my practice, and it was so wonderful, and to be able to care for women and to really provide a much needed part of medicine that we're all largely missing in the conventional side of medicine. But as I started growing my practice and being the CEO and also a full-time clinician, I really was burning myself out. And also when you start to fight the insurance companies and other potential physicians who may not agree with you, it can become quite stressful. And I realized that I needed to make some significant changes in my life. I also unfortunately had the loss of my mother, my father, and my sister in a short span a few years back. And it got to the point where I was overwhelmed and completely burnt out, even though I was in this space of medicine, and it made it so much better compared to where it was before. When you're practicing conventional medicine, you feel like you're in a wheel, a hamster wheel, over and over again, fighting the man, and also insurance companies. But being in anti-aging helped that tremendously. But medicine is still problematic in having to try to still have a good living and providing for yourself financially and fighting the fight. So I had to make a difficult decision, and it was actually the right decision because ultimately I wanted to sell my practice down the road, and I did a year ago, to a company that could infuse more capital and do things. But I had to make some choices in my life to rebalance my life, because I realized, although most women we want to do it all, maybe just not all right now, all at once. So I've lived the dream of kind of building and growing my practice, and now I want to consult and help other people build their practices, which will revitalize that joy in my life from that burnout that occurred and taking on too much.
Congratulations with that.
Thank you.
What advice would you give to other physicians that might be experiencing that same feeling of burnout?
I think physicians in particular, and any clinician that practices medicine, we give so much of ourselves into our patients and our care. We got into this profession usually for noble reasons and altruistic reasons and wanting to help and care, but unfortunately we're terrible at caring for ourselves. And really taking back some of that power to say, yes, it's okay to care for myself, and finding ways to bring back joy into either what you're doing or to move on, because there may be a window that you really enjoyed it, but now there may be other opportunities that you can step into. But it's okay to find joy in medicine, and anti-aging is a wonderful way to do that in a lot of ways, because you can get out of the drudgery of medicine and people not feeling better, and you can actually make people feel better, which is very rewarding and can give you some of that indirect joy. So that's what we did this for in the first place. So I think it's really about reassessing your life and reassessing your profession and not accepting it as is, and saying, you know what, I can make a change. Even though it might be scary, just jumping off that precipice, but there's many of us that did do that, and it was worth it once you get to the other side. So just, I think, reevaluate, find the joy, be happy. You're allowed to.
No regrets along the way.
Oh, I think there is some, but they usually involve men or some bad nights at a slot
Professional.
machine. But no, I'm kidding. But no, professionally, it's all been worth it. I think you have to take the good with the bad, and it all gets you to the same place of being who you are and being able to help. And ultimately, I want to be able to leave that mark in medicine and say, you know what, I made a difference. I left medicine a better place, even if it's just a little piece. That's what I think we're all trying to do.
Well, Dr. DeRosa, I think we will leave it at that. I thank you so much for joining us today.
It's been my pleasure.
Best
Thank
of
you
luck
so
with your
much
new
for having
venture.
me. Thank you.
And thank you for all of your help and trying to get all of us women and men feeling better. So
Thank you.